speaker is going to be talking about a piece of research. And with any research, it's one study, and that hasn't yet changed clinical practice or prescribing. And we know when you hear something, it can be very tempting to think, oh, I should change this, I should change that. But just to reiterate, our speaker cannot give you medical advice. It's really important to speak to your clinician before changing any medication, because they can take account of the entire medical history that you have. It's a pleasure to welcome Dr. Susanna Zuurbier. We first met, it was now 5 years ago, wasn't it? The Cavernoma Reliance UK Forum, and I presented a check as a well done and a thank you and a congratulations for winning our Cavernoma. It was our first prize then. So it's so lovely to welcome you back tonight, and thank you for making time to speak with us. So Yvonne Zuurbier was working with Professor Rustem Al-Shahi Salman, who many of you will know as the chair of our Medical Advisory Board. And she is now a neurovascular consultant at the University Hospital of Antwerp. So I will now hand over. Thank you so much. We really appreciate your time tonight.
Thank you very much for the invitation. And it's a real honor to be here together with so many participants. So I'm happy that my research is of so interest for all of you. And I'm currently working as a neurovascular consultant at the University Hospital in Antwerp in Belgium. I will start the presentation with some personal background of me. Thereafter, I will start with my interest for female hormone therapy, and thereafter I will discuss the article about female hormone therapy in cerebral cavernous malformations. And at the end of the presentation, there's time for questions. Well, I'm living in Amsterdam in the Netherlands, and I did my residency in neurology in Amsterdam at the University Medical Center. And there I become specialized in cerebral venous thrombosis. And that is a rare disease, and it occurs especially in women, and the cause is a clot in the veins that bring the blood from the brain to the heart. The treatment consists of blood thinners, and one of the causes is also using female hormone therapy. I've published around 50 articles about this topic in different collaborations and around the world. When I almost finished my residency in neurology, I decided to go to the United Kingdom, to Edinburgh, to do a research fellowship training under supervision of Professor Al-Shahi Salman. And there my interest for cerebral cavernous malformation was created. We published an article about long-term antithrombotic therapy, which are blood thinners, and the risk of brain bleeding from a cerebral cavernous malformation. And the article was published in the Lancet in Neurology in 2019. And we found that blood thinner therapy was associated with a lower risk of brain bleeding from the cavernous malformation. And now I will mention one of the important things for the presentation today, because we thought that the brain bleeding may be triggered by a thrombus in the dilated caverns of the cavernous malformation, in which the blood flow is slow, or thrombus in an associated venous malformation, because when you have a single cavernous malformation, there can also be an associated development venous anomaly. So our idea was that maybe there's a thrombus that caused the bleeding, and therefore the blood thinner therapy was helpful. So this is important because this is also the reason that I decided to do an investigation about female hormone therapy in patients with a cavernous malformation. We found that antithrombotic therapy may be beneficial for the prevention of brain bleeding for the cavernous malformation. But as mentioned already by Helen, we have to investigate this before in a randomized control trial, before doing this in clinical practice. So it's not that you already can use blood thinners, but we have to investigate it again in a randomized control trial. Here you can see me that I received the Cavernoma Alliance UK prize together on the picture with Helen. And Helen is handing me the prize. And so again, thank you very much for receiving that prize. And it was a wonderful experience to be honored for something that I would love to do. I continue my work about cerebral cavernous malformations. I published an article together with Professor Alcee Salmon about propranolol and statin medication. Thereafter, I published the article about female hormone therapy, and currently I'm working together with Professor Alcee Salmon about an article about cerebral cavernous malformation that we hope to publish in Practical Neurology. Well, now I will discuss with you my personal interest for oral contraceptives and female hormone therapy in general. Well, it all started with cerebral venous thrombosis. That was a topic that I became specialized in during my residency. And in this disease, it occurs equal in men and in women a long time ago. And also in pediatric patients, you see that it is equal in men and women. But now it is more common in women, 3 times more in women than men. And the most explainable reason is the use of oral contraceptives. Oral contraceptives increase the risk of cerebral venous thrombosis 5 times. And I found out that when you are obese and you are using oral contraceptives, the risk is almost 30 times increased. So that was an important finding. And underlying cause of the thrombosis in the cerebral venous system is a thrombus in the veins that brings the blood from the brain to the heart. And therefore, the European Stroke Organization advised that women of fertile age and with a prior thrombosis should be advised against its use. So when you have a thrombosis, they advise you to stop your oral contraceptives. Unfortunately, they do not mention what they have like alternatives, but we advise coil. Well, also in the arterial system, the system of the arteries that bring oxygen to the brain, there can occur a thrombus, which causes an arterial stroke. And that can also be caused by oral contraception. It's the same as in the venous system. And here we are with the cavernous malformation, which is between the artery and the venous system. So I was thinking, when here a thrombus occurs, which can be caused by oral contraceptives, and in the venous system a thrombus can occur due to oral contraceptive, maybe it's also the case when there are thrombus occur in the capillaries from the cavernous malformation. So therefore, I decided to investigate this. Well, I was also asked by the European Stroke Organization to help writing on the guidelines on the management of menopause, pregnancy, and postpartum. And when you have an acute stroke, the guideline advised to stop hormone replacement therapy to prevent a recurrent stroke. And 2 days ago, I was invited by the World Stroke Organization for a webinar about transgenders and the risk of stroke and venous thrombosis. And especially in trans women, the risk of stroke and venous thrombosis is increased, and most probably due to gender-affirming hormone therapy. But today, I'm here with you, and I'm going to talk about cerebral cavernous malformation and the use of female hormone therapy. So here we have the cerebral cavernous malformation. And the current evidence about female hormone therapy use is very little. There was only, before my publication, 1 case report. It was published in 1999. It was in French, and it was about a 26-year-old woman. And she developed brain bleeding 4 times while she was on hormone therapy. And the 4 episodes of bleeding occurred, and when she stopped with hormone therapy, the bleeding stopped. So it was only one case report, but therefore they thought that maybe hormone therapy was an underlying risk factor. Then we have one observational study. It is the observational study from Kelly Fleming. In total, there were 180 women and 42 presented with hemorrhage. 26% of the women presented with hemorrhage were taking estrogen. There were 20 women that were taking estrogen. 13 of them were using oral contraceptives. 3 used a topical patch, and 3 hormone replacement therapy, and 1 topical estrogen cream. So Kelly Fleming divided the group in familial cavernous malformation and sporadic cavernous malformation. And there were 5 out of 23 patients with a familial cavernous malformation taking estrogen, because in total there were 20. But 2 out of these 5 presented with hemorrhage. And 15 out of 95 patients with sporadic cavernous malformation were taking estrogen, and 9 presented with hemorrhage. So that were the findings from Professor Fleming. And I decided to contact Kelly Fleming, the neurologist in the United States, and also Philip Demman from Germany, a neurosurgeon, if they wanted to do research about female hormone therapy use and the risk of bleeding in cavernous malformations. And they were both interested. So the aim of my study was to determine the association between female hormone therapy use and the risk of symptomatic intracranial hemorrhage in females with a cerebral cavernous malformation. The population. Participants were adults, first diagnosed with a cerebral cavernous malformation, and they were aged 10 years or older. And the patients were admitted to the University Hospital in Essen in Germany between 2015 and 2021, or to the Mayo Clinic in the United States between 2003 and 2020. We collected data on female hormone therapy from the patient's medical record and standardized questionnaires. And the exposure was female hormone therapy use. And this includes all types of oral contraceptives, estrogen and or progesterone, and all types of oral, transdermal, and local menopausal hormone therapy. And patients with an intrauterine device were included into our analysis, but they were regarded as non-female hormone therapy. And our outcome was bleeding, and the time point was up to 17 years of follow-up. Here you can see the results. In total, there were 722 adults, and 137 had ever used female hormone therapy. That is 19%. The median age of the group of persons with female hormone therapy was 34 years old. In the group of no female hormone therapy, the median age was 44. The mode of presentation was a bleeding in around 40% in both groups. A cavernous malformation multiple were present in around 17 to 21%, and the brainstem location in 26 to 25%. So there were no significant differences between both groups. And here you can see the baseline characteristics. So here you can see a more detail of the patients in both groups, but the most important things were already explained in the previous slide. And here you can see the results. This is one of the most important slides of my presentation. And because this is the association between female hormone therapy and the risk of a new bleeding. The red line in the figures shows the patients with female hormone therapy. And in the blue line are the patients without female hormone therapy. On the x-axis are the person years of follow-up, and on the y-axis, the risk of brain hemorrhage. And what you can see is that the risk of brain hemorrhage is higher in female patients with hormone therapy. Out of 137 patients on female hormone therapy, 46 developed a brain hemorrhage, and that is around 34%, versus 91 patients out of 585 patients. So that's 60%. So there was a big difference between both groups in the occurrence of brain hemorrhage due to female hormone therapy. Well, there are some limitations about my study. It was not a randomized controlled trial, and we were unable to separate the different types of hormones, like formulation, dose, routes of delivery, all of which affect the risk of thrombosis. But female hormone therapy use was associated with a higher risk of brain bleeding from the cavernous malformation in my study. But additional prospective observational studies are needed to further understand the possible role of female hormone therapy in cavernous malformations in females. So thank you very much for your attention.
Lovely, Yvonne. Thank you so much for sharing that with us. That was much appreciated. So I know some questions were submitted to you in advance. So I think it'd be timely to move on to those. And just to remind everybody, Dr. Zuurbier will start with the questions that were pre-submitted, and then we'll move on to the questions that are in the live Q&A. So if you haven't already asked a question, now's the time to do that. Thank you. So yes, Dr. Zuurbier, do you want to move on to the first question?
Yeah, I've also it on my slides. So the first question was, is that a good idea to go on the slides and then the answer with me?
Yes, I think that'd be super. Thank you.
Yeah, okay. So one of the persons asked about, I'm diagnosed with multiple carcinomas. I'm probably genetic. And for several reasons, my children do not know and do not want to know at this stage whether they have a cavernoma or carry the gene. My daughters use contraception. And what is your opinion on this? So, well, I've written my answer. And it's, to be honest, a hard question. But my opinion is that since the diagnosis of cavernous malformation is unknown, it is crucial for young women to be protected against pregnancy and to use a form of contraception. My study shows an association, but other studies have not confirmed it yet. So the study did not show which form of anticonception is the best choice, for example, or which dose. And for that, further research is still necessary. Therefore, it is essential to make an individualized choice, which is also dependent on other factors, like smoking in combination with oral contraceptive use, for example. Because I also found in my study, which I haven't mentioned before, is that when you use oral contraceptive and you are smoking, the risk increases from 2 to 5. So that is also something to take in mind. But a coil looks like a safe option. Then I received a second question. If someone has the genetic cause of cavernomas, then they may want to have genetic in vitro fertilization, so they don't pass the gene onto their children. And the egg collection for in vitro fertilization requires the women to have a high dose of hormones to stimulate the release of the egg. The first question is, could this also increase the risk for bleeding for the some reasons that other hormone therapies do, or is it okay because it's for a short period? Well, to be honest, we do not know if in vitro fertilization treatment increases risk, since there were 2 other participants with this special case. But some fertility medication increase the risk of blood clotting, which theoretically could increase the risk of brain bleed from cavernous malformation. And if a patient desires this, it is maybe important to discuss this with your neurologist, because the risk of bleeding is, for example, also dependent on if you have had a previous bleeding or if you have a location in the brainstem. So that is my advice in that case. Do they know of being on hormones for longer periods of time is a bigger risk, or whether the dosage of hormone is the bigger risk? Well, that's also a very interesting question, but we do not know if longer time periods are a bigger risk or whether the dosage of hormone is a bigger risk. But there are hundreds of combinations of estrogen and progesterones, and we believe those with the lowest dose of estrogen are probably less risky, but we do not have the data yet to know. And certain progesterones may have less risk than others as well. And these are all things that need additional exploration. This is only what we know for patients with venous thrombosis, like deep venous thrombosis or pulmonary embolism, in which a large number of patients are already investigated about this topic. Another question is, it'd be less risky to be on contraception such as NuvaRing, where the dose of hormone is much less because it's more localized. Well, we also don't know if a NuvaRing where the dose of hormone is much less risky. So we don't get the answer now. And the third question is it safe to be on the copper coil? Can the copper coil make your cavernoma grow in size or bleed? Well, since the copper coil is non-hormonal, we do not think it increased the risk of bleeding, but currently we are not sure because there's no data about this yet.
Excellent. Thank you so much, Yvonne. And have we come to the end of the questions that were pre-asked now?
Yes.
Lovely.
And I think there's another question. Should I mention that also?
Oh, yes, the one that came in just before the presentation.
Yeah, and can the hormonal pads or injection make a cavernoma get bigger because of the progesterone levels? Well, we have not looked in our article about the growth of a cavernoma, but this is also, of course, a very interesting research question. And then there was this question. The fifth question, I'm in my menopause and I've been suffering chronic urinary tract infections since it started. I have had to take almost monthly antibiotics to treat them and had little choice in treatment. New research from America is quoted with references. In The Guardian and discussions with my GP have advocated the use of a very low estrogen gel to use regularly, which has proven really successful in treating urinary tract infections. I did want to check with you first that it is safe given its low dosage before I commence regular treatment. Well, I did not show my answer, but I think, well, there is an increase about hormonal treatment, but it's also important to treat the urinary tract infection. So it's always a balancing of risk between, for example, in this case, urinary tract infections and hormone therapy. And my advice is to discuss this with your general practitioner and see if this is the best treatment options. But I think when it's only a very low estrogen and it's a gel, it could be a treatment option.
Lovely. Thank you so much for going through those and to the members who submitted those questions in advance. So, Dr. Zuurbier, if I could ask you just to stop screen sharing, and what I'm now going to do is to move into the last questions, of which we have 12 already. So lovely. So if you could, stop the screen.
Oh, yes, I stopped sharing my screen.
That's marvellous, fabulous. So I'm going to take them in the order that they've come in. And just a reminder, if anyone's put any questions in the chat, if you could put them in the Q&A, just because we don't want to miss them. So the first question is, I'm interested to know if anything has come up about women who suffer fibroid cysts, etc., regarding Cavernoma fidens. I ask as I've got several issues. I'm around the age of 40, and it resulted in the Mirena coil, which my body rejected, and then it's gone on to more serious fibroid issues, resulting in bilateral salpingo and operectomy, and then finally the diagnosis of intermedial spinal C3 cavernoma. So I think, as I understand it, the crux of that is the question about fibroid cysts and cavernoma and any connection known about that.
Well, to be honest, I do not really understand. What do you mean with 5 point?
Yes, it's probably there's probably a different word for it in the Dutch. What we could do for that question, so it's fibroid cyst. It's where you have formed in the womb, or they're basically sort of little pockets. What I'd suggest there is I will email that one to you, and then we can follow up
Good.
On that one. And I'll just make a note of the member who's asked that question. So the next question is there any evidence of the effects on a cavernoma, my bleed was 8 years ago, of estrogen pessaries used post-menopause?
Well, in my study, there were 137 patients using female hormone therapy, including oral contraceptives and menopausal therapy. But the number of patients using, for example, a pessarium is very low. So it's not possible to say that type of menopausal therapy can increase or not increase the risk, because well, it's so less patients that we have to do a bigger research to really say something about that.
Yeah.
So now we mention only menopausal therapy in general.
Yeah, thank you. And I think that's a recurring theme, isn't it, about the need for more research? And that's something at the UK, we're passionate about and would love to see your research continue. And so pleased you've started that. But yes, it'd be amazing if there could be funding for more research. So the next question, is the Fleming study, in the Fleming study, is there a baseline of bleed rates in patients not taking estrogen?
I mentioned that around 42% out of my head having and I need to go back to the slide. Maybe that's an option, which I can see.
Yeah, please do screen share again.
She mentioned that 42 presented with hemorrhage out of 180 women. So that is around, let's see, I thought 14, that is 36% presented with an hemorrhage. But that were all women, and she did not mention it. Well, she also mentioned that 11 presented with hemorrhage and taking estrogens. So 36% in total, and 11 with estrogens. But I don't know if that is an answer on the question.
Oh, well, I think we can take a note of that, but I think that definitely goes to answering the question. So thank you. We're putting you on the spot here today, aren't we? This is just a comment. This is a high number of questions for a webinar, which I think speaks to how interested people are in this subject.
Yeah, that's already fantastic.
Yeah, which is amazing. And just before we go on to the next question, we've got a few people in the chat saying, should I stop taking HRT? Is there 100% risk? And what I just reiterate, which we said at the beginning, and is important to say, is that Dr. Zuurbier's findings are at a research stage. And just for those who may be less familiar with research, what happens is you get your research study and you have to do quite a few trials before it gets to a point where actually they change decisions about what medications are given to people. And that's because this is a small study, it's one study. We need bigger studies with more patients, and then a final decision can be taken. So in answer, is there 100% risk? No, at this stage. We've got data that points to there being a risk, but we need more research. And please do not change the medications you're taking without speaking to your clinician and discussing it with them, as everybody's health history is different and we need to weigh up the risks. So the next question. My understanding is that transdermal estrogen does not present the same risk of clots as oral methods. I appreciate the studies don't distinguish between the different routes of how that's administered, but I'd welcome your thoughts. So a question there about whether the delivery mechanism for the hormone therapy, is that going to impact?
Yeah, yeah. What we know from studies about venous thrombosis, like deep venous thrombosis in the leg or pulmonary embolism, is that we found that transdermal routes are less risky. So that's what they found in these studies. So I agree that oral intake have a higher risk, but I'm not really sure if that is also for cavernous malformation, but it looks like if there's the same mechanism.
Yeah, and I think you raise a really important point there, don't you, about the stroke risks for hormone therapy for the general population, and we know about the risks there, and then like working out what's specific to the Cavernoma population. Thank you. So the next question is, so someone's just asking for clarification. So female hormone therapy includes even oral contraceptives with only progesterone and no estrogen. So just a question there about whether it was only combined or whether actually progesterone only is also considered.
Yeah, well, it included estrogen or progesterone or a combination. So we used them all in one group because the numbers were too low to make only a decision for estrogen or only progesterone or the combination. So we used them all together. So we cannot make an answer which oral contraceptive is the best or the
Yeah,
the
thank you.
lowest risk. Mhm.
So the next question. I have a coil at present. I did use the contraceptive pill in the past. Have there been any studies regarding the use of a coil?
There are no studies regarding to cavernous malformation and the coil. But the idea is also from the studies from venous thrombosis that a coil is having a lower risk than oral contraceptives, for example.
Excellent. So the next question is, thank you so much for the presentation. You know, lots of people are really appreciating your time here and what you've shared. And the question is, for the similar conditions you mentioned at the start of your presentation, have full-scale trials research been completed? And could any of that data be ready across to Cavernoma?
Um, I do not really understand the question because do you mean that for cerebral venous thrombosis that we know that the risk is increased for using oral contraceptive and that there are trials for that, or?
I think that may be the question. And to the member who's just asked that, perhaps if you could just pop in the chat, if you're on the chat at the moment, what I'd
Mhm.
suggest is if that member just adds that clarification in the chat, and then we'll come back to it.
Ah, yeah, perfect. Yes, because
Lovely.
there are studies from deep venous thrombosis or pulmonary embolism about hormone therapy.
Okay, excellent. Next question. Do you know if there's a difference in the risk between the combined or estrogen only pill? And I guess that's probably a two-fold question. One is in the general population, and then in the
Uh-huh.
population of Cavernoma patients.
Yeah, so in the Cavernoma patients, we don't know because we bring all the patients in one group if they use estrogens or if they used a combination. But in the general population, um, when you only use progesterone, then you have the lowest risk, as far as we know now.
Thank you. Thank you. So I'm just going to go to the chat because there's a question there, which is probably one for me to answer. And a member said, GPs and neurologists give such varied feedback. What advice is feedback to professionals or where they can get advice? And just to say, at Cavernoma Alliance UK, we're very, very familiar with this. Some GPs have spent time learning about Cavernoma, but the majority may never have heard of it. And you may go
Mhm.
to your GP and they give one bit of advice, and you see a neurologist or neurosurgeon who knows Cavernoma well, and they give different advice. We have on our website information for any clinician to read up on the condition. In our experience, though, it's the neurologists and neurosurgeons who will understand your Cavernoma the best and be able to give
Mhm.
advice in respect to that. But also, we know sometimes people get different opinions from neurologists and neurosurgeons. And it's okay to ask for a second opinion. For rare conditions, that's very, very common. So please, if you're getting different viewpoints, don't be shy to ask for a second opinion. Clinicians absolutely expect it for rare conditions. And Dr. Zuurbier, I know you've worked in the NHS as well as in where you are now. What would your advice be for people who are saying, oh, do I speak to my general practitioner? Do I speak to my neurologist or neurosurgeon?
Yeah, well, it depends. In my country now, we see a lot of patients with a cavernous malformation by the neurologist. But it also depends if they have been treated by operation, then they will follow up more common, for example, by a neurosurgeon. Yes.
Excellent, thank you. So the next question is, I'm 59 years old. I have a sporadic cavernoma in the brainstem, and I had a bleed in 2019. I started taking estrogen at 750 micrograms. I did not know there was a risk, so just stopped taking it. Should I continue with this medication, in your opinion, or not?
Well, it also depends on what kind of symptoms there were for their problems that they start making the choice to start with a therapy, and if their symptoms are still there, or if it is fine already to stop with that medication. So that's a balancing of the risk of how good you feel now without the treatment and with the treatment. But the most safe option is to stop with that treatment if that's fine and you don't have any symptoms about it anymore.
Yeah, and I think just to reiterate what we've said before, Dr. Zuurbier has drawn on her knowledge of her research, but we would always say to members, speak to your clinician before making changes to your medication. And that really important point you raised there, Dr. Zuurbier, about weighing those risks. And the clinicians will be weighing up your whole health history because everybody's risks vary depending upon their medical history. So thank you very much for that. So the next question, where do you think, this is a good one, where do you think your research will take you next? What do you think is the next stage of this understanding? I think we're all going to be very keen to see where you take this, because I think there's a lot of people keen to know more and to see that main phase trial happen.
Yeah, well, that's a lovely question. Well, to be honest, I don't know where my next research will go about. But I'm, due to this webinar again, very inspired about this topic that I would love to continue. But well, I still need to find some funding for it and to found our larger population and to set up everything. But it would be great to do more investigation about this topic to have more clear answers for all of you.
Yeah. And just to say, from Cavernoma Alliance UK's perspective, something we're now going to do is when people approach us to talk about any research for Cavernoma, we're going to ask the question, will you specifically ask if women are on hormone therapy? And then you can monitor them and analyse that data separate. Because actually, as we all know, often with research, women's issues are overlooked. That data isn't gathered. And that's something we're very, very keen to see happen. So we will be advocating for all researchers to take that into consideration as a point of analysis for their research. So the next question, I think you've answered in part already, which was, did you include women on progesterone-only pills, which you've said yes to? And again, people really keen to probe into, is it the estrogen or is it the progesterone? And this person saying, could it be to the estrogen rather than the progesterone? I think you've probably said we just don't know at this point, but is there anything more you'd like to add on that?
Well, from the other studies, they think that estrogen is the main important thing for a higher risk, and thereafter the progesterone. So, but we don't know in cavernous malformation. Because we combined it in the whole group.
So the next question, and they keep coming, which is like, people are loving this webinar and very keen to hear more from you, which is super. So thank you. But if you need a glass of water, have a sip.
No, it's fine.
This question is, I'm 50 and considering HRT. Just to be clear, does your research mean that different types of HRT, because we've talked there about different means of administration, etc., may have different risks of bleeding? And is there one form of HRT that you consider to be a lower risk? And I guess there's two parts to that, isn't there? There's stroke risk in general, and then there's stroke risk for cavernoma patients based on the research you've done.
Yeah, for Cavernoma patients, we have plotted to one group, so there's no difference between oral or transdermal, for example. So there we cannot say anything. But for the group of the general stroke, there the idea is that the oral tablets, for example, have a higher risk than the transdermal patch.
So I think that's a really interesting point for those who have joined today, isn't it? That knowledge that this is in the general population where there've been bigger studies. And I think that's just an important point to reiterate. The study you've done is a small group for Cavernoma, but a lot of work has been done to look at stroke risk in the general population who are taking hormone therapies and to know that difference between whether you're having it transdermally or orally. Okay, so the next question. I had a bleed within the first 6 months of starting HRT. I've been on it now for over 2 years. I have a right frontal cavernoma, 2.2 centimetres, that was discovered post-bleed. Should I stop HRT? And I think we've said before, we really can't advise on whether to stop or start medication. Is there anything more you'd like to add to that?
Well, they also found in the general population that the risk of bleeding is increased especially in the first year when you start the medication. But we don't know in our population, but that is something that I found.
Yeah, so making that point that for the general population taking HRT, there are stroke risks, hemorrhage risks, and they're more likely to happen in the first year than later years. But more data, more research needed. I think you're going to have a lobby group of people going, please, research on this. So going on to the next question. I just wanted to know if my copper coil would affect my cavernoma. I'm due my MRI scan next month. So I think we've spoken a bit through this about copper coils, but anything else you'd like to add on coils?
Yeah, well, about the copper coil, it's non-hormonal, so you should have think that there's not an increased risk, but well, we don't know, but that's one of the most safest options. You should think about it, but um, there were almost none patients with a copper coil, so we don't know the real effect because we have studies with only copper coil and no treatment, for example.
Again,
But it looks like when you have the idea about hormone treatment, then the copper coil doesn't have any hormone treatment. So it looks like the most safe options.
Just to say in the chat here, people are saying if you need study participants, you know where to find them. In the UK, you'll have a lot of people who'll be wanting to take part. So we've got another question on cysts, but I think that was covered earlier. So this is an interesting question because we often get a lot of chat about this in our closed Facebook group, and that's about menstrual cycles. And so the question here is, could there be more risk at different times of the menstrual cycle, for example, when hormones are higher?
Yeah, that's a very interesting question. And I've heard that before by some people. But to be honest, I don't know. And I haven't investigated something like that. It's not something that I really often hear from other types of stroke, for example, but maybe that's also there. But yeah, I do not know if there is a relation. There's no research about it that I know for so far, but
And I
yeah,
think
it's
there's a
very interesting.
Yeah, and there's a common theme here, isn't there, about the lack of research in this area and the opportunity there. And that's something we can really advocate for because I think that'd be really interesting, wouldn't it, to monitor menstrual cycles and to see how symptoms vary. And we can have anecdotal comments on that. It'd be great to see that researched. So the next question. On an earlier slide, you mentioned propranolol and statins. I was approached by my GP to consider statins because I've had a stroke. Was your research also advocating for statins? And I think just to clarify, we don't advocate with the research, do we? We're sort of exploring, but absolutely take that point. But with your research advocating for statins post CCM hemorrhages, and the person says, I've seen mixed views on statins.
Ah, yeah. Well, that's correct. Because in my study, I did not find a statistic significant increase or decrease of the hemorrhage. So I should not advise to start with statin therapy for patients with a cavernous malformation until there's more research with a randomized control trial.
Yeah. Excellent, thank you. So the next question, I think we've already answered, but just to see if there's anything more you'd like to add. And the person says, I'm sure the cohort is too small, but is there any evidence of higher bleeds during the natural high estrogen in the cycle without taking medication? So just looking, this is now in terms of the general population. Do we know anything about stroke risk, hemorrhage risk, and a woman's cycle?
Sorry, what do you mean exactly with human cycle?
Oh,
That
oh,
during when they have their bleeding, that couple of days. Do you mean that? If
yes,
then there is an increased risk.
yeah.
Yeah, well, I haven't investigated, I haven't looked for that. I haven't read anything about it, that maybe there is some evidence about it, but I'm not sure about it. And it's not that I see patients, for example, with cerebral venous thrombosis, which have a very high risk when they are using oral contraceptive, or that it's not that they all mention, oh, it occurred when I had my bleed. It's not very common that I've heard something about that.
Yeah.
But interesting question, but
And then we had a question asked earlier, I'll just repeat it, which was for the similar conditions you mentioned at the start, have full-scale trials and research been completed? And then they've just come back with a follow-up here, which, because there's so many questions, which is marvellous, I found it now. And they said, yes, I meant for the research done for other health conditions. Has enough research been done to have conclusive data that is being acted upon by the medical profession?
And then enough research data about what exactly? About
I think it's other conditions and stroke risk, hemorrhage risk, I think is my understanding.
when they are using oral contraceptive or hormone replacement therapy?
Yeah.
Yeah, well, and there are other diseases which have an increased risk due to hormone replacement therapy. Especially I'm interested in stroke and venous thrombosis, so I know that that risk is increased, and especially in cerebral venous thrombosis, the risk increased. And for example, the risk was increased in cerebral venous 5 times, but when you're obese, the risk increased 30 times. And it's also when you're using oral contraceptive and you're smoking, for example, then also the risk increased. And that is all from other diseases that we know this information.
And I think that's a really important point about smoking, isn't it? I think particularly for Cavernoma, it can often feel that there's a lot outside of our control. And neurologists are saying, let's wait and see. But things like smoking, stopping smoking can make a big difference, can't it,
Yes.
to the risk of a hemorrhage?
Yes.
Excellent. So the next question is again about progesterone and increased risk. And I think we've talked about your study covering both progesterone only, estrogen only, and then combined. And then the final question that I've got here, and I'll just check if there's any more. You'll be thinking, final. And that is, I'm aware soya products have an estrogen type effect. Does a diet high in soya products increase risk? So I think we're looking at sort of somebody saying, if I were to eat a lot of soya beans or drink soya milk, that's going to lift my estrogen levels. Could that then give me more risk?
That's also an interesting point. Well, I haven't heard anything about that before. And so I don't know. I haven't looked in the data for that.
I think that'd be an interesting one to do a comparative study, for example, with a university in Japan or China, to where the diet is higher in soya beans, to have a look. I mean, these have been absolutely fascinating questions. I'm just going to have a quick scroll through the chat to see if there's anything that we missed here. I mean, someone makes a really good point about it's tricky balancing risks. They said, I have osteopenia, so really keen to keep taking HRT to protect my bone density as well as manage symptoms. I'm also taking transdermal estrogen. And I think that's the point we were making throughout this about everybody's health needs are different. And whilst there can be risks, there can be benefits as well. So it's really important to talk that through with your clinician so we can weigh that up. No, there's also a point here. We talked about, who do you speak to? And somebody shared, they went to their GP. We told them to speak to the neurologist, and the neurologist didn't answer the question. And on that, we get this a lot on the helpline. Some neurologists are very knowledgeable about Cavernoma, and some are less so. And if you feel your question hasn't been answered, for rare conditions in particular, it's okay to say, I'd like a second opinion. I'd like to speak to another neurologist. That would be our advice as an organisation, to ask for that, and it being okay. Don't feel that you're in any way going to imply that they don't know, or clinicians are really used to receiving those requests for second opinions. So thank you so much, Dr. Zuurbier, for your time today and your generosity in answering the questions that have been posed to us. It's been incredibly helpful. I've just had 2 more come in, so let me just quickly take these quick ones, and then we're going to wrap up. The question here is, I'm on a diet, it's low calorie, and I get lots of headaches. Is this a big no-no? So again, it's a question about diet and kind of whether a low calorie diet is going to be causing any problems.
To be honest, I'm not sure if a low diet can cause some problems. If you have new habits which is new for you, or you get additional symptoms, it's always important to go to a doctor or to check if it's new or if it's something else. But I'm not aware that a low diet is giving an increased risk for a hemorrhage, for example. We only know that an increased risk for a hemorrhage is when you have had a previous hemorrhage or a location in the brainstem. So I think, but when you have some doubts about it, you can always contact your general practitioner, for example.
Yeah, absolutely. And we say the same on the helpline. If you've got a new symptom, or if there's a substantive change in your symptoms, don't be shy. Do ask. Well, this has just been fabulous. Thank you so much. Just to remind people, on the CAUK website, under the home section, we have a link through which is titled HRT and oral contraception, where we link through to Dr. Zuurbier's research. So if you'd like to read that research paper, you can click on there and read it. And that also includes our statement being clear that this is one trial. We'd love there to be more, and to have what we call the more definitive trials, so that then clinical practitioners have very clear guidance in terms of prescribing. But we hope today we've helped raise awareness of the question here and that potential risk, to help inform your thinking and understanding. So thank you. We look forward to keeping in touch, and it's lovely, 5 years on, to have you back talking to our members today. So thank you so much.
Yes, thank you also very much. It was a real honor to do that.